minutes talking about some of the antimicrobials which are just starting to come online and those that we can look to come online in the next year or two. And then I'm going to hand over to Alison, and then Alison's going to hand back to me to have a second bash at empiric treatment of complex bacterial infections later on this morning. So I have some disclaimers. I am in receipt of public sector grants and private sector grants, and I will try not to let them influence me over the next 25 minutes or so. So we're going to start talking about gram-negative infections, and then we're going to move on to gram infections, and then we're going to look to the future. But before we can look forward, we must always look back. And you will have seen this kind of graph in all of its many forms many times before, detailing how we had the glorious, wonderful years in the 50s, 60s and 70s, before I was born even, where we developed a multitude of antibacterial agents to help us in our fight. However, what happened with amazing alacrity after each new antimicrobial was developed was the development of resistance, and that persecutes us even up to this day, when even some of our new antibacterials, which I'll come to in a moment, we have already detected resistance to. So when we're thinking about antimicrobial resistance, it is a jigsaw, and it is a complex jigsaw that needs the pharmaceutical industry and academia and all of the drug development agencies to step up to combat all of these different areas. But right now, we're just going to focus on these four for the next 10 minutes or so. On ESBLs, which I know are as common in Jordan as they are in the UK, and then carbapenem resistance, and by those I mean carbapenem resistant Enterobacteriales, Pseudomonas, and Acinetobacter. So let's start with the beta-lactams, because you're comfortable with beta-lactams, I'm comfortable with beta-lactams, and they're probably the most prescribed class of antimicrobials in the world. And we have been using the pen and the carbapenems with aplomb for the last 50 years, right? And that is why we have such a problem with ESBLs and carbapenem resistance. What's happened though, and as you know, is that the beta-lactam inhibitor compounds have become less effective when coupled with the existing beta-lactam partners. And by that I mean amoxicillin and clavulanate, or I mean piperacillin and tazobactam. And as the complexity of the ESBL and carbapenem resistant genes increases, and as they spread, those existing beta-lactam inhibitor compounds are not serving us as clinicians in the way in which we need them to work. So what's happened is that 4 new beta-lactam inhibitor compounds have come to market. And some of these you'll know, and some of these will be on the horizon, and forgive me, because I do not know quite where the regulatory agencies in Jordan have got to with licensing these. And I'll comment on where our regulatory bodies have got to in allowing us to use them in the UK. So the first of these is Ceftazidime-avibactam, which I think you guys do have, and we have had for about, I guess, 18 months, 2 years now in the UK. And Ceftazidime-avibactam has achieved its licensing through no less than 7 phase 3 studies, which I think is a credit to the manufacturers. And these are the reclaim, recapture, and reprove studies. And you'll notice that reclaim, recapture, and reprove are fairly standard phase 3 licensing studies, where they are giving their drug, Ceftazidime-avibactam, against a reasonable competitor for a set organ system infection. So intra-abdominal, UTI, and hospital-acquired pneumonia. And it met the modified intention to treat outcomes, and that's lovely. But what is really useful about Ceftazidime-avibactam was it was the first phase 3, or one of the first phase 3 studies that actually directed its agent against difficult to treat pathogens in a per pathogen study, rather than the infected organ system. So it didn't matter where the organ was, it was just, do you have resistant organisms, and does our drug work? And that was a reprise study, and it found non-inferiority to best available therapy. But of course, licensing studies are just those. And what is perhaps more useful to you and to I as clinicians is the real world data. So the real world data has taken that reprise study model. So that model that pits the drug, in this case Ceftazidime-avibactam, against for a set pathogen, irrespective of which organ is infected. So if you look at this prospective US study, first of all, from Van Duyn, they pitted Ceftazidime-avibactam against colistin for KPC carbapenemases. And you can see there in these Kaplan-Meier curves that actually Ceftazidime-avibactam has a significantly reduced hospital death compared to colistin. And if you're anything like me, then you are as scared as can be of colistin. We really don't use it unless our backs are completely against the wall. So following on from that prospective US study, the Spanish did a prospective per pathogen analysis, real world data this, of Ceftazidime-avibactam, this time against a different CRE, this time against OXA48 producing Enterobacteriaceae. And as you can see, they did it for a variety of sources of infection. It almost doesn't matter where the source of infection is because it's a beta-lactam, right? But it's the nature of the resistance of the organism. And again, if you flick your eyes down to the mortality data, then, you know, for Ceftazidime-avibactam in OXA48, we're seeing 1 in 5, possibly 1 in 4 people die. But compare that to your other agents, and actually, you're certainly, in my opinion, saving 3 out of 4 patients with invasive OXA48 organisms is a real boon to my practice. The second beta-lactamase inhibitor I want to just touch on is Ceftolozane-tazobactam, so here we have several trials again as at a per organ system trial design, again for complex intra-abdominal infections, for UTI, and most recently the ASPECT NP study, which focused on HAP and VAP. But I would draw your eye to the fact that for Ceftolozane-tazobactam, it can be dosed at single dose for complex intra-abdominal infections, paired with metronidazole, and it can be dosed at single dose for UTI. But for pneumonia, they had unfavorable results when dosed at single dose, and so they did double that dose. So if you look down, then it's 2 grams of Ceftolozane plus 1 gram of tazobactam, TDS, for pneumonia. And I draw your attention to that because that has, at least in our reimbursement system in Western Europe, a significant impact upon the cost of Ceftolozane-tazobactam, and to be factored in. But again, these are just licensing studies, right? So in terms of real world data, then Sarah Jorgensen from the US replicated her previous work, which she did for Ceftazidime-avibactam, and used the same kind of model to look at Ceftolozane-tazobactam. Again, just this is a per pathogen analysis, so almost irrespective of the organ system, just looking at does it work. And bearing in mind, of course, Ceftolozane-tazobactam is being marketed, and for good reason, as an anti-MDR Pseudomonas beta-lactam-beta-lactamase combination, then you can see that actually the 30-day mortality of about 1 in 5 is really quite, it's still not great, but it's pleasant from my point of view when people with MDR Pseudomonas invasive infections are almost guaranteed to have a poor outcome in my practice. So Ceftazidime-avibactam, Ceftolozane-tazobactam, and then we're moving on to the 2 which are not licensed in the UK yet. And as I said, forgive me that I do not know where they are licensed in Jordan. The first of these is Meropenem-vaborbactam, which has been brought to market based upon the TANGO trial. So TANGO 1 was a licensing study to achieve FDA clearance for urinary tract infections. That was fine. But pathogen studies where it pitted Meropenem-vaborbactam against best available therapy for hard to treat organisms, and it showed non-inferiority and perhaps even a trend towards superiority. And the same for Imipenem-relebactam, which were the RESTORE studies. So the RESTORE studies, again, were licensing studies for complex intra-abdominal infections and UTIs, but then again were pitted against those difficult to treat organisms. So I think across all 4 of these beta-lactam, beta-lactamase inhibitor compounds, what's really, really beneficial to our practice is pharma really engaging with the fact that we need pathogen studies against our difficult to treat organisms, rather than just per organ system studies, as the FDA and in Europe the EMA were wanting prior to, I guess, half a decade ago. So for the beta-lactam inhibitor agents, that creates a complex picture, right? So we have here Dr. Doy and David Livermore put together very similar tables, and this is a really nice one because it reminds you what indications are. But you can see how now it is super important that each of these new beta-lactamase inhibitor compounds is coupled together with rapid turnaround diagnostics. Because if we cannot diagnose just the pathogen, which we can all do, but unless we can diagnose the mechanism of carbapenem down to the level of OXY48 versus KPC versus MDM, you get the picture, then actually it becomes near impossible to choose the correct beta-lactamase inhibitor. And indeed, launching in empirically with one of these is, depending upon your epidemiology, probably dangerous, which means that we need to integrate rapid molecular diagnostics into the patient pathway. I'm just leaving that there as a little marker because we'll come back to that in my second talk a little bit later on this morning. We cannot prescribe agents without the diagnostics to support it. But let's move away from beta-lactams and let's just touch upon our own friend Tigecycline, which we have all been prescribing for over a decade. You have, we have, everyone has. And we've probably been prescribing in fairly similar ways, you and I. We've been prescribing it for complex intra-abdominal infections. We've been prescribing it for complex skin-to-skin structure infections. And we have not been prescribing infections or pneumonia. But if your experience of tigecycline is anything like mine, you will have found a reasonable amount of pancreatitis as an adverse event from it, and your patients will have been vomiting their guts out because it is quite emetogenic. The FDA has, of course, raised a black triangle in the UK, I'm assuming it's called something similar in Jordan, around tigecycline, saying there is an increased risk of death if you use it inappropriately, and therefore it should be an antimicrobial of last resort. So welcome to the market, therefore, a cousin antimicrobial, Eravacycline, which is again basically a tetracycline molecule which is souped up. And its licensing studies were again against intra-abdominal infections and complex skin-to-skin structure infections, with really very good outcome data against the comparator, which in this case for intra-abdominal infections was meropenem. Now, when you dig into the meat of that, and of course it is important to dig into the meat, as we were saying for the beta-lactams, when you think about which pathogens are causing it, you can see that Eravacycline really has very good activity, comparable and in some cases better than meropenem against gram-positives and gram-negatives and anaerobes, which really makes it a very attractive option for intra-abdominal infections and complex skin-to-skin structure infections, diabetic feet, osteomyelitis, and so on. But what's really pleasant about Eravacycline is that there is a decreased adverse event profile compared to tigecycline. So possibly, so equivalent in my mind, possibly superior, but take that with a pinch of salt, but less of a toxic profile than tigecycline. Then there's something which we've been using in the UK as an oral formulation for many, many years, which is Fosfomycin. And forgive me if you have a world of experience with this, but last year, of course, Dr. Kay and colleagues in CID put forward the final results of the ZEUS, using Fosfomycin as the oral sachet for just a lower urinary tract infection. Instead was pitting intravenous Fosfomycin against Pip-Taz for acute pyelonephritis and complex urinary tract infections. And it was at least equivalent. And interestingly, it worked against, as you can see here, the spectrum of different pathogens which cause urinary tract infections. But what was, again, super interesting about the ZEUS study was that they did break it down to a per resistance mechanism outcome data. So here across the white top lines, you're seeing ZTI-01, which is Fosfomycin, against Pip-Taz. For ESBLs, equivalent. For aminoglycoside resistant organisms, equivalent. For CREs, equivalent and possibly superior to PIP-TAZ. That's not a big shock because I wouldn't use a TAZ for a carbapenem-resistant organism, but certainly look at that outcome data for fosfomycin monotherapy. That's really attractive, and the same for multi-drug resistant organisms. So actually, for urinary tract infections, fosfomycin may be a way forward. Then we move on swiftly from fosfomycin to the novel aminoglycoside, which is plazomycin, which in my mind is a super sad story. So when we were speaking here last time and the time before, we were thinking about how plazomycin may be really good news, may have extended spectrum compared to gentamicin and amikacin, may have an improved safety profile compared to gentamicin and amikacin, and indeed it kind of bore that through in its head-to-head licensing study for urinary tract infections, complex urinary tract infections that is, when it went head-to-head against meropenem. Look at that data there suggesting that plazomycin is better. However, plazomycin was brought to market by Archaeogen, and soon after the FDA licensing trials, when it achieved FDA licensing for urinary tract infections, but did not get it, did not get it for bacteremia arising from urinary tract infections, Archaeogen went bust. So plazomycin has recently been bought up by a manufacturer of off-patent drugs, and you can get it. Suffice to say, the manufacturing chains are not as robust as I would like them to be, and it is painful trying to obtain this drug, at least in the UK. And then Cefiderocol, and Cefiderocol is soon to arrive in the UK, and I am both excited beyond belief and in terms of waking up at 3 AM in the morning cold sweat about this drug. So for those of you who haven't been following the Cefiderocol literature, it's been brought to market by Shionogi as a novel cephalosporin that gets in to the periplasmic and cytosolic space through a Trojan horse mechanism. It's a siderophore cephalosporin, meaning it binds to iron, and of course no microorganism can survive without iron. Ergo, it cannot close off its pores, it cannot have an effective efflux pump, so therefore the Cefiderocol gets to where it's needed and then acts as a standard beta-lactam thereafter. And if you look at these MICs against this wealth of gram-negative organisms, and you just flick your eye down those Cefiderocol MIC50s and compare that by flicking your eye down the MIC50s for Ceftazidime and for Meropenem, you'll see that really in vitro Cefiderocol is super attractive. But what have Shionogi done with it so far? So to date, they are focusing on complex urinary tract infections and acute pyelonephritis. And their head-to-head trial, the APEKS trial, pitted it against Imipenem, and you'll see there that really quite convincingly the outcome data favors Cefiderocol. Now that's great, but the reason I wake up in the 3 AM with a cold sweat when thinking about Cefiderocol is, if we just go back to this slide, well, that's most of my gut flora. And the extreme spectrum of activity of Cefiderocol may act in its advantage, but it may actually act in it as a disadvantage when we, as infectious diseases doctors, pharmacists, scientists, are trying to live in a realm of antimicrobial stewardship. Having such an extreme breadth of spectrum of activity may actually be a deficit rather than an advantage. So that was the first half, right? That was a quick run through gram-negatives. I'm going to talk about ESBLs, and then many of my colleagues in the room there are going to talk about MDR Pseuds, MDR Acinetobacter, and CRE treatment this afternoon, and they'll dig into those agents in more depth then. But really, as conclusions for pipeline antimicrobials for gram-negatives, we have the beta-lactamase inhibitor compound, which we are all starting to get confidence in using, but I would stress you must couple use of these agents with rapid molecular diagnostics to discern which carbapenem resistance mechanism you are dealing with, and hence choose your beta-lactamase inhibitor appropriately, or else we are all scuppered. Second is the Eravacycline really is filling me with glee, because I do like Tigecycline. I have very good outcome data with Tigecycline. It's just a little bit of a dirty drug. And then fosfomycin and plazomycin. So watch this space about getting access to plazomycin. But fosfomycin, we've picked up and run with the outcome for the ZEUS trial, and we're using fosfomycin a lot.